We'll go ahead and get started. Hello there and welcome to the webinar, Making the Case for Collaborative Care, a deep dive on executing and scaling the CoCM model. I'm Will Crowley, the Senior Director of Marketing here at NeuroFlow and the host for today's webinar. And over the next 45 minutes, we'll set the stage for why collaborative care is so important, discuss how to make the case for CoCM in your organization, and how to execute these programs successfully. And before we get started, just covering a few housekeeping items. The webinar will be recorded, and we'll send that recording out to everyone who registered. If you have any questions, please click the questions icon in the chat and submit those in. We'll leave 15 minutes at the end of the discussion to dive into those, or if one is timely, we'll get into it throughout the session. Please don't hesitate to ask questions throughout the presentation. We'll try to address those as we can. I wanted to introduce our main speaker here. I'm joined by Dr. Tom Zaubler, the Chief Medical Officer here at NeuroFlow. Tom is the former Chair and Medical Director of the Department of Psychiatry at Morristown Medical Center, the founder and Medical Director of Pegasus Psychiatric Associates, and Tom has over 25 years of expertise on implementing and financially supporting the delivery of the collaborative care model into major health systems. Tom, thanks so much for joining here today. Excited to learn more about collaborative care and share the knowledge and how healthcare organizations can establish these programs. So I'll let you go ahead and take it away here, Tom.
Thank you, Will. It's a pleasure to be here. Hi, everyone. So we're going to take a deep dive into some of the reasons why collaborative care is such an important model of care, given the current behavioral health crisis that we're facing in the United States, talk about the model itself, talk about some of the challenges in implementing this model of care, and then we'll talk about what can be done to help to implement and scale collaborative care using technology. Okay, Will, I'm not able to advance the slide. If you could advance, there we go. Okay, so first of all, we know that psychiatric illness is incredibly common. About 1 in 5 people have a psychiatric illness in the United States, 57.8 million people. About 14.1 million people have a serious mental illness that causes significant impairment. These are the patients that can drive significantly increased medical cost and utilization, medically complex patients with co-occurring medical and psychiatric illness. We know that fewer than 1 in 3 patients who actually receive any mental health treatment at all see any improvement in their care. We'll talk about why that is in just a second. And then there's this remarkable statistic that 60% of people in this country with a mental illness in any given year receive no treatment at all. Imagine if that were cancer or heart disease or diabetes. We know that psychiatric illness, depression, anxiety drive substantially increased medical costs, 50 to 100% more. In fact, some studies show that the cost can be 2, 3, or even 4 times greater in those with co-occurring psychiatric illness than in those without. There are close to $300 billion annually of increased medical costs related to underlying psychiatric illness. So the importance of addressing the prevalence of psychiatric illness in the population is not only important in terms of quality of life, not only important just in terms of managing depression. You can't have health without behavioral health, but it's also important in addressing the entire healthcare ecosystem and the economics of that ecosystem. We know that if we successfully integrated psychiatry and behavioral health into medical settings, that we would save close to $50 billion annually in costs. And we'll talk about why in just a second. So psychiatric illness rarely occurs alone. It can, but when you look at, particularly with depression, anxiety, when you look at illnesses like chronic pain, cancer, people with neurologic disorders such as having a stroke, diabetes, heart disease, rates of psychiatric illness are very high. You can see from this slide, rates of depression for those with pain can be as high as 60%. Post-stroke, rates can go as high as 40 or 50%. Those with heart disease, extremely, extremely high. And when we talk about psychiatric illness driving increased costs, there are many, many reasons for that. Some of them have to do with the fact that patients with psychiatric illness may be less likely to comply with their treatment for their underlying medical condition. They also can have physiologic links between their underlying psychiatric illness and their underlying medical problems. So for example, individuals with thyroid disease have reasons why they may become depressed from a physiologic perspective, and vice versa. Depression can affect endocrine function. There was a fascinating study looking at patients who had a recent heart attack and looking at different cohorts. So there was one cohort of patients without depression, and there was another cohort of patients in a control group with depression. The patients with depression were the intervention group. The control group were patients without depression, and those cohorts, they were controlling for body mass index, controlling for how well the heart was pumping, the ejection fraction, controlling for a whole range of medical factors that attempted to make any adjustments and differences in those populations. And what the study found was that 6 months out, 17% of those with co-occurring depression were deceased, as opposed to only 3% of those without depression. So we know that depression and psychiatric illness is critical to treat in medical populations and for those with co-occurring medical and psychiatric illness. And the consequences are substantial: increased morbidity, mortality, and costs. This slide underscores the importance of addressing psychiatric illness in those who are high utilizers, these distressed high utilizing individuals, the 20% of the population that account for about 80% of all healthcare costs, or in the top 5% of patients that account for about 50% of all healthcare costs. If you look for that in that top 5% of patients, the average annual cost is about $50,000 per person. When you compare that to the bottom 80% of utilizers of medical services in the population that only account for a total of 20% of all healthcare costs, it's $276 per person. So the costs are enormous. And again, when you look at that distressed, high utilizing population of patients, between 60 to 80% of those individuals have psychiatric illnesses. I'll show you in a slide that will drive that home in just a second. Bottom line is the more medical problems that one has, the more likely one is to have depression or anxiety or psychiatric illness. So it's super important to identify surface psychiatric problems in general, and specifically in this population of individuals who are constantly seeking care for underlying medical problems, because diabetes, heart disease, many medical problems often really don't improve very much unless the underlying psychiatric problem is addressed. This slide drives home that point, that if you look at this distressed high utilizing population, well over 50% of that population struggles with an underlying psychiatric disorder. With major depression, it's close to 70%, or it's about 70%, panic disorder close to 25%, and you can see generalized anxiety disorder, alcohol use disorder. These are very common diagnoses. We know that in primary care, about 20 to 40% of patients have an underlying behavioral problem. And often that underlying problem drives why patients are presenting to a primary care physician. So you see patients presenting with headache, back pain, tinnitus, these vague somatic symptoms, and often they're fueled by underlying depression and anxiety. Often people aren't even aware that they are depressed and may present with these physical symptoms that are simply not getting better. And then over time, if they're lucky, the depression or anxiety or psychiatric illness may get diagnosed. Primary care is a de facto mental health center for all patients with psychiatric illness, or for most patients with psychiatric illness in this country. About 80% of all antidepressant prescriptions are written by primary care physicians. We know that in primary care, there's increasing amount of screening. The United States Preventive Services Task Force has recommended screening for anxiety and depression in primary care. And yet, despite that, about 50% of the time, psychiatric illness goes undetected in primary care. And when it is detected, in fact, when depression, anxiety, and other psychiatric illness is detected, only about 20 to 40% of patients actually get better without seeing a psychiatrist or behavioral health professional. Part of that has to do with the fact that primary care physicians are really challenged to do way too much in a very compressed visit with a patient. Managing all the physical problems, the psychosocial issues, and the psychiatric issues is a very tall task, especially if you have a 15-minute follow-up appointment with the patient. So patients fall through the cracks, the follow-ups are not at a sufficient frequency to make sure that patients' needs are being addressed. Lots of challenges. The antidepressants the dosing is not adjusted, patients aren't getting the psychotherapeutic and care management support that they need, so they fall through the cracks. So the majority of patients, when they're even diagnosed, in fact, don't get better. Now, patients can be referred to specialty care, to specialty mental health care from primary care, but that also is a challenging thing because, first of all, we'll talk about the workforce challenges in just a second, but there's a stigma. Often patients are reluctant to see a mental health professional, and only about 50% of the time do patients actually follow through with those referrals at all. So the reality is that the majority of patients with psychiatric illness in primary care and elsewhere just simply don't get adequate care. We know that in our child and adolescent population, the prevalence of psychiatric illness is very significant. COVID has underscored that and accelerated that substantially. About 50% of all pediatric visits involve some sort of behavioral, biopsychosocial, or emotional issue. 20% of adolescents experience an episode of depression by age 18. 8 to 12% of teens have an anxiety disorder. And then there's this remarkable statistic that really underscores why psychiatric illness is so disabling, why depression is the leading cause of disability in the world. 50% of all lifetime cases of mental illness start before age 14. 75% start before age 24. So the reality is that psychiatric illness starts early in life, and while we have really excellent treatments, they are not curative. They treat the underlying problem, and there are things that can be done to prevent a recurrence of depression and anxiety, but without that treatment, the likelihood of recurrence is very high. So if you have one episode of depression, 50% chance it's going to come back. 2 or more episodes, about an 80% chance. 3 or more, close to 90% chance. We know that in an adolescent population, there's an 8 to 10 year lag between onset of psychiatric symptoms and treatment initiation. And in that 8 to 10 year lag, there are a lot of consequences. It can lead to truancy from school. It leads to poor socioeconomic achievement, dropping out of school early, not graduating from high school or college, substance use, a whole range of phenomena. So it's incredibly important that we narrow that lag, that we identify kids at a much earlier age. I'll talk in just a second about the rate of suicide, but particularly in this young population, about 1/3 of all adolescent girls have reported seriously considering suicide over the past year. So it is super critical that we surface the underlying psychiatric problems, we assess for safety in our adolescent population. Suicide overall for all age groups, the 10th leading cause of death in the United States, 2nd leading cause of death for those between 10 and 14 and 20 and 34. So in that young population in particular, very concerning, over 48,000 suicides last year. And what's so striking when you look at the suicide decedents, those who have died by suicide, 45% have seen a primary care physician within 1 month of the suicide. 77% have seen a primary care physician within 1 year of the suicide. Those rates are much higher than seeing a behavioral health professional. So again, why it's so important to address psychiatric illness and try to address issues around prevention of suicide prevention within primary care. This slide underscores the fact that most patients with psychiatric illness do not present in behavioral health settings. They present in medical settings. 70% of patients, roughly, with underlying psychiatric problems have co-occurring medical problems. They present with their psychiatric problems in medical settings for their care. And what's so striking is that 95% of all behavioral professionals work in either siloed or primarily siloed behavioral health settings. So there's a misalignment in terms of where we have our professionals and where those who have psychiatric illness are trying to have their care needs met. In terms of the shortage, the vast majority of primary care docs report having trouble finding mental health specialists. In 55% of counties in the United States, there is literally no psychiatrist. 77% report a severe shortage. In the state of Maine, there was a 50% drop in the number of psychiatrists between 2015 and 2020, and there was a wait time of up to 1.5 years. Really striking statistic. Maine is not the only state with numbers like that. 70% of psychiatrists are 50 and older. So this is not going to get better. And this is not just for psychiatrists, it's also for psychotherapists. So the demand is going to outstrip supply in a very significant way by at least 25% by 2025. So that brings us to the collaborative care model. In order to address how ubiquitous psychiatric illness is and the fact that people with psychiatric illness drive utilization of medical services, and they tend not to get better medically if the underlying psychiatric problem is not addressed, and combine that with the workforce challenges. There are simply not enough mental health professionals out there. We have to look at these population-focused models of care that leverage limited resources, that allow the healthcare ecosystem to treat patients within medical settings for underlying psychiatric illness, and really reserving those who are most acutely ill with the most acute psychiatric problems for psychiatrists and behavioral professionals to treat, because there are, again, simply not enough mental health professionals to treat everyone. So psychiatric collaborative care. So the first thing to know about this is that this is an evidence-based model. It's been around since the late 1990s. I was very fortunate to have been mentored by the individual who started this model at the University of Washington in the 1990s. The model is, there have been over 90 randomized controlled trials establishing tremendous efficacy. The original trial was with 1,801 patients over 18 primary care sites, and the model was compared to a treatment as usual group, which included, and I'll explain the differences in just a second, included primary care practices that had co-located therapists or psychologists. The primary care docs in the treatment as usual groups could prescribe antidepressants, could do a whole range of things, including having social workers in the practice engage with patients. The collaborative care group, and again, I'll explain the model in just a second, substantial reductions in depression compared to the usual care group. So over 40% of patients had significant reductions, 50% reduction or more in their depression scores as opposed to 20% in the treatment as usual group. So very substantial reductions in their depression scores, and the results are durable. So what the studies have shown over and over again is that even after patients graduate from this model, they do well over a period of years. So this is the model. It's a team approach. It entails screening for psychiatric illness in the primary care practice. Ideally, there's universal screening, and there's a team of people with the patient at the center of this team. The team includes the primary care doc, and what's innovative about this model is the primary care doc is actually doing the prescribing. There's a lot of clinical decision support that primary care doctor is going to get. There is a psychiatrist involved in this model, but the psychiatrist is actually not seeing the patients directly. Psychiatrist is going over a caseload on a weekly basis of the patients seen by a behavioral care manager. Usually that's a master's prepared clinician, although it could be a paraprofessional, it could be an RN, it could be a whole range of people. That behavioral care manager is helping to provide care coordination, provide some therapeutic interventions, problem-solving therapy, behavioral activation, motivational interviewing. These are all skills that can be taught relatively quickly and easily to a behavioral care manager. Behavioral care managers can also do cognitive behavioral therapy, a whole range of interventions with patients. The psychiatric consultant and the behavioral care manager will meet, usually on a weekly basis, to go over the caseload of patients. So how does that caseload accrue? So what happens is when patients screen positive, the primary care physician sees that. They will then do a warm handoff. So the patient comes into the office for a visit. There's a warm handoff to the behavioral care manager. Now that behavioral care manager might be on site, or in a virtual world, it could be that the behavioral care manager, it's a virtual warm handoff, could provide that care virtually. The care manager enrolls the patient in collaborative care. and the care begins. And that process includes continuing to measure how patients are doing. So this is measurement-based care, treatment to target. It's accountable care that makes sure that no one falls through the cracks. And all this data flows into a registry that the behavioral health manager keeps and provides critical information to the primary care provider. That registry also allows the behavioral care manager and the caseload supervising psychiatrist to go over the caseload. So again, they'll meet on a weekly basis for about 3 hours. They'll work with any patients that's new to the collaborative care practice. They'll look at patients who are at risk, and there are ways of identifying that risk that I'll go into in just a second. They'll look at patients where there are safety concerns, adjust medication. They make those recommendations to the primary care physician, make recommendations in terms of modifications in the type of intervention, psychotherapeutic or care management interventions. So a whole range of things are occurring in that model. And the patient is right there in the center. The care is delivered in the primary care practice in a seamless way. What this results in is significantly improvement in their depression and anxiety, leads ultimately to remission in a significant percentage of patients, cost reduction, patient satisfaction goes way up, provider satisfaction goes way up. The collaborative care team, as I was saying, comprised of the primary care provider and then 2 behavioral professionals, care manager and psychiatrist. All 3 of those individuals working as a team. The billing for this, interestingly, is done incident to the primary care doctor, so it's not carved out into a behavioral health plan. It's billed under the primary care physician, yet the primary care physician does the least amount of work. Primary care physician does the prescribing, helps with the warm handoff, but really then hands the care over to the behavioral care manager and that consulting psychiatrist. The patient then will work with this team to choose an antidepressant and or psychotherapy. If there is an alcohol use disorder or substance use disorder, they will engage in treatment for that. Historically, collaborative care was intended for people with mild to moderate depression. There have been a growing number of studies looking at this model for patients with more severe psychiatric illness like bipolar disorder or PTSD, ADHD, and so on.
Hey, Tom, I'll give you a chance to catch your breath. All really good stuff. We had a question actually come in that is pretty relevant and timely. What are your thoughts on the reimbursement model for primary care settings to account for this increase in scope and resource need when it comes to collaborative care?
Yeah. So yeah, thank you for that question. So there are these fee-for-service codes for collaborative care, and most insurance carriers are now paying for those codes, and over half the states have Medicaid rates, and of course Medicare is paying. These are recognized by CMS. So there is a mechanism in a fee-for-service world for primary care practices to collect reimbursement, and because it's on the medical side, there's not a concern about carve-outs. So there is a significant amount of revenue that can be garnered. The billing is done in an accrual basis monthly, so there has to be time tracking and so on. There can be technology to help with that. But the reality is, in a fee-for-service world, you can recoup the costs involved in doing this. There's also work being done legislatively, and in policy decisions are being made that will help to provide support for the cost, help defray the costs of implementing these programs. So right now there is legislation, bipartisan legislation in Congress that we hope passes, that is going to increase Medicare payments for collaborative care to help with those costs. There are a lot of barriers. One of them is cost. So there are also innovative relationships between payers and providers, where payers are now helping to defray some of those startup costs, because payers recognize when patients get their psychiatric care addressed, their utilization of services, medical services, goes down. So there's a lot going on, but the short answer to that is there is reimbursement for these models of care. That wasn't the case before 2017. So we've come a long ways, and I think there's more and more benefit. Now, beyond all of that, there are significant savings. So in any risk-based payment model, significant savings because of the decreased utilization that health systems and medical groups and providers can get if they're engaged in any sort of pay-for-performance metric like CPC plus or primary care first, or now it's about to be called making care primary, and so on. But so just a little bit of perspective on covering costs. Any other questions, or I can?
We'll save the rest for the Q&A, but feel free to go ahead there, Tom. Thanks.
Okay. Well, I can't, for some reason, I can't advance the slides again. There we go. So collaborative care improves access to care. PCPs get input on patients' care throughout the week, certainly throughout the month. There's regular communication with a caseload supervising psychiatrist and the behavioral care manager delivering the care. They're meeting on a weekly basis. They may talk in between appointments that they have with one another. Because the psychiatrist is not seeing the patients directly, they may cover 10, 20, even 30 or 40 patients in a 3-hour meeting, as opposed to seeing just 3 or 4 or 5 patients. And over time, the care is shaped based on how patients are doing. Again, this is measurement-based care, treatment to target. So if patients are getting better, great. If they're not getting better, antidepressants may be changed, dose may be adjusted, corrections can be made to ensure that patients get better. We go to the next, yeah. And what you see is that substantial cost savings. Now, often the horizon is about 3 years out, but for every dollar you invest in this model of care, there's about a $6.50 return on that investment. So substantial savings in costs. And the largest savings are on the medical side: decreased inpatient medical costs, decreased ED visits. Initially, there may be an increase in behavioral costs, but over time, those go down as well. The goals: symptom relief, of course, improvement in quality of life for patients. Really important that this meets the quadruple aim. Physicians, primary care docs get tremendous satisfaction when they see their patients getting better, not only psychiatrically, but medically. So it's a bit of an antidote for burnout. There can be decrease in the total cost of care over time. And it's also an issue around equity. This is a model that entails universal screening for psychiatric illness. Social determinant screening can also occur in this model and ensure that to the extent that there are health behaviors that are impacting one's overall health and behavioral health, that can be addressed in this model. And then reduction of stigma, since the care is integrated within primary care. So one of the challenges here is that this model has been around, as I said, since the 1990s, and yet the uptake of any integrated model of care in primary care is around 30 to 40%. Collaborative care is significantly lower than that. So we have a model that we know that works, is very effective, population focused, and yet the uptake is low. Now, part of that is that question about finances. Well, we now have CPT codes, and that has helped to drive acceleration. We see that, for example, in the state of North Carolina, the Medicaid rate increased reimbursement to 120% of Medicare. And that has driven a significant increase in collaborative care in the state of North Carolina. We hope that other states follow that lead. There is legislation to increase Medicare reimbursement, so that may help. It's very challenging for primary care practices to take on a new model of care when they are challenged with seeing an enormous number of patients. They're often living in an RVU world where they have tremendous demands on their time. So it's hard to change management, hard to get them to adopt to a new model of care. What you find is once primary care docs learn the model, and once it's implemented, provider satisfaction goes way up. So the challenges have to do with the fact that there's universal screening. Practices have started doing screening now for depression and anxiety. It's often done a little bit haphazardly. Some practices, some groups are doing it through EHR, some are doing it manually. Part of the challenges is doing universal screening, and trying to automate that using technology can be very helpful. Creating workflows that ensure that there is collaboration across the entire care team, identifying steps for patients with those behavioral health needs. What can they do to get support when there are acute conditions or when there are safety concerns? And then the financial sustainability piece is critical. We've touched on that a little bit, and come back to that, but these are some of the challenges. And this is also where technology, and I'll come back to this point in just a second, can make a big difference. So scaling collaborative care, very hard to scale. One of the reasons that I got engaged with technology is that I was implementing these collaborative care models in primary care using pen and paper screens that were then manually input into Epic, and it was very challenging to do the screenings and to manage all the requirements of collaborative care without technology. So what you see on the left are the core principles of collaborative care. They include that it is team-based care and truly patient-centered care. It's population-focused. You're dealing with large populations of individuals. It's measurement-based treatment to target, which we've touched on. That there are not only the index scores that determine who gets enrolled in collaborative care if they score positively for depression, anxiety, or any number of other illnesses that could be screened for, but it's ongoing assessments to make sure that patients are getting better. It's evidence-based care, mentioned all the randomized controlled trials, and it's accountable care. No one falls through the cracks. The challenge is how do you do this in primary care? How do you automate the screenings? There are ways to do that through technology that allow for practices to send out bulk invites to large populations of patients and do screenings remotely that integrate with EHRs. There's an ability to then provide ongoing assessments and provide self-management tools to patients depending on how they screen for their depression and anxiety. So a lot of the processes involved in collaborative care can be automated and done very simply through technology. Another thing that technology can do is determine the patients who are at greatest risk, whether they are at risk of self-harm or if there's been a significant deterioration in their functioning. There are alerts that get triggered through technology, through triage engines, and as a result of that, they get populated in the registry, and the care manager and the psychiatrist reviewing the care can identify those patients who are most at risk and devote a substantial amount of time in their reviews to those patients and change care as needed. When patients trigger an alert where there's a concern about safety and suicidality, there are mechanisms with technology to deliver resources to that patient. So if they're completing a screen at home at 2 in the morning, they can get a message either in a platform or an email alerting them to local resources, national resources to get help. There is technology that allows an immediate response from a clinical person who can then talk with the patient, do an evaluation, and assess whether they need to go to the emergency room or not, and ensure safety. And so that's another critical variable in something that technology can support in primary care. We know that the level of risk can vary quite a bit. So if you have patients on a platform in between appointments with a behavioral care manager, or let's say they've graduated from collaborative care, and typically patients are in collaborative care from about 3 to 6 months. They've graduated from collaborative care, but they're still on a technology platform and they've now had a deterioration in their condition. That platform can pick that up, trigger an alert to the primary care physician. The patient can be re-enrolled. If there's an alert that triggers a concern about safety, there can be a response to ensure that that patient gets the care that they need in a timely fashion, potentially averting something catastrophic. And then the last point that I'll make, and then I'll stop for questions, is we also want to make sure that when patients become more acutely ill, and that can happen in a collaborative care context, if they go to an emergency room, we want to make sure that they get adequate care in the emergency room, and that upon leaving the emergency room, or if they're admitted upon leaving the hospital, that they can be closely tracked and followed. And again, if you have technology, you have a patient on a platform looking through an app, let's say, where they are assessed and safety can be monitored on a very regular basis, and interventions can occur to ensure safety before they get to their outpatient appointment, whether it's in a collaborative care context or in a higher level of care. Care becomes very fragmented when patients become acutely ill, and the technology can help to create a full continuum of care and ensure that patients don't fall through the cracks no matter where they are in that care. So let me stop there. A lot of ground that we covered, and see what questions there are. Happy to revisit any of these points.
Tom, thanks so much for all the insights there. One of the first questions that came in was, how would you suggest the PCP and the behavioral health care manager or the psych consultant build trust and align on treatment models in collaborative care?
So first of all, there's a lot of training that the BHCM and the caseload supervising psychiatrists will go through before they engage in this model. So this is not something that psychiatrists or social workers or others often learn about in their training. So one has to go through training, and there's online training. There are resources to get that training. So and there are established models that really work, focusing on often very simple interventions, problem-solving therapy, motivational interviewing, behavioral activation. What gets utilized in this model depends on how the patient presents. So if you have a patient presenting with significant depression, they're apathetic, they're not engaging socially, there might be a lot of focus on behavioral activation, getting them up, getting them out, getting them doing things, helping to create structure and a schedule, while a primary care physician in this model is prescribing an antidepressant. Over time, as they engage more, there can be positive reinforcement to encourage and facilitate that engagement. So it really depends on the needs of the patient. There will be a discussion with the patient about what's working and what isn't working. We'll know that because there's ongoing measurement-based care treatment to target. So if patients are getting better, we'll see that, both in terms of what patients are telling us, telling the behavioral care manager when they meet with them. We'll also see it in the scales they're completing. So it really has to do with this very fluid communication in the entire care team, with the patient right in the middle of that team, communicating with the behavioral care manager on a regular basis and ensuring that their needs are being met.
And thanks, Tom. And another question that came in is, the model's been around for a while. What do you see as kind of the future of collaborative care and the way it's delivered and executed on? Sort of anything, kind of insights or kind of the next phase of it, if you will.
Yeah, I think that that there's been a significant uptick in implementation of collaborative care over the past 5 years or so. And part of that has to do with reimbursement mechanisms that are in place now. More and more Medicaid, state Medicaid programs are covering it. So FQHCs are now coming on board. And then COVID, of course, accelerated the demand for behavioral services in primary care. So there's a greater and greater recognition and familiarity with this model. So what we're seeing is more and more primary care providers expressing interest, having an understanding of this model, and a greater interest and willingness to take this on, understanding that there's going to be a learning curve and some disruption to their workflows, but knowing that overall it will improve their quality of life, the provider's quality of life, and very importantly, the patient's quality of life and their medical well-being. So what we're seeing is greater and greater upticks, and we're seeing greater use of technology to help scale these models across large populations. So, you know, what I think is going to happen is much greater adoption of these models. And what's really sobering is that the outcomes with these models of care are comparable to what you would see if a patient were seeing a psychiatrist or a psychotherapist on an individual basis weekly for 45 minutes. So really robust outcomes done in a way that allows people to get their care met seamlessly, integrated in primary care or other medical settings with robust outcomes. So I think that's the future, and more we're going to see this model integrated not only into primary care, but into subspecialty settings as well.
And it's a good transition, Tom, into probably our final question is, what's the difference between CoCM and behavioral health integration, specifically in an FQHC?
So there is a continuum of behavioral health integration. You know, what some practices have includes some integration where a social worker or a psychologist might be co-located. So FQHCs often have a social worker providing care management support and also some support for behavioral problems. That may not be a truly integrated model of care. Some FQHCs have a more integrated model, but you know, where patients are essentially referred to that social worker who's on site, but seeing patients on their own and then providing some feedback to the providers, the primary care providers in that FQHC or practice. That's different than a truly integrated model where you really have a team-based approach. So what we see are, you know, we'll see places that have some level of integration, some level of screening, And over time, they advance on a maturity curve from screening and engagement to some care coordination, and over time to deploying a model of integration that is truly team-based. And there are different models. In addition to collaborative care, there's something called PCBH, primary care behavioral health. There are differences between those models, but they are very population focused, and there's not one model alone, although collaborative care is the one that has the largest evidence base, which is why there's been a tremendous focus on that model.
That's great. And it's a good reminder, Tom, that we've put together a pretty extensive manual or white paper kind of guiding organizations through that continuum of care. And everyone who's attending today will get a copy of that as well as a follow-up. That kind of wraps us up on a time perspective. Tom, I just wanted to say thank you and give you any chance to sort of say any final closing words here before we wrap up.
No, listen, a pleasure to give this talk. I appreciate everyone's interest. You know, what we're seeing with 48,000 suicides every year, with over 110,000 overdose deaths every year, we're just seeing so many reasons why it is so critical to address these needs, from a quality of life perspective, to save lives, and to really help to manage our healthcare ecosystem in a way that makes it sustainable. So thank you all for coming. I appreciate your interest, and happy to engage offline if anyone has any additional questions or comments.
Great. Well, thank you, Tom, and thank you to our attendees for making this such a great discussion. So enjoy the rest of your day, and thanks again.